Okay, welcome everybody. We'll get started. I want to make my introductions. We're so happy to have you here. There's many that are still trying uh, to get in, and we will have that all seamless for everyone. I'll go ahead and make introductions. Thank you to the North Shore School Social Workers Consortium. You came to us and asked us to present on this topic today, and we were blessed to have Dr. Coleman as an expert in this topic. I am Lori Kehoe, a member of the outreach team at SunCloud Health. I'm joined by my outreach colleague, Donna Bartlett. SunCloud provides integrated, nuanced treatment with residential, PHP, IOP, and virtual services for adults and PHP and IOP for adolescents ages 12 to 18, focusing on treating the whole person. And we're located in Naperville, Northbrook, and Lincoln Park. If you're interested in updates, and we will have several in the next months, we'd love to come and visit with you and your teams. If you'd like to schedule trainings for your teams, your teachers, your students, and your parents, we offer those free of charge. Please contact Donna or myself. And our contact information will be, as usual, in the final slide. And we will be giving you copies, the PDF copy of this presentation for reference. And of course, to make a referral, you can contact one of us directly, or you and families can call intake directly. That number will also be listed. Donna and I will be following up with you as well after today's webinar. And lastly, we are in the final stages of planning our fall CE Adolescent series, which many of you have been attending the last several on a monthly basis, and we're glad to be able to provide that for you for free of charge for CEs. And again, they're always geared toward topics that are related to the work that you do with students in student support. And again, for today's CE credit, you will receive an email including the quiz and the survey. So please complete those. And then you should receive your CE certificate by email within the next 7 days after you complete that. Today's presenter, very proud of it, very proud of him, is our very own adolescent psychiatrist, Dr. Johnathan Coleman. Dr. Coleman joined the SunCloud team in March of 2022. He received his Bachelor of Science in Chemistry after studying at Washington and Lee University. After earning his Doctor of Medicine at the University of Louisville School of Medicine, Dr. Coleman completed the Adult Psychiatry Residency Program as well as the Child and Adolescent Psychiatry Fellowship Program at the University of Illinois at Chicago. He is also board certified in both adolescent and adult psychiatry. Originally from Bowling Green, Kentucky, Dr. Coleman's interest in mental health grew as he did. He's always enjoyed working with kids, so he specialized in child and adolescent psychiatry. He is passionate about his work helping kids and families reach their full potential through proper mental health treatment. Providing help and relief to a population that is often overlooked and misunderstood brings him great joy. And with further ado, I introduce you to our speaker, Dr. Johnathan Coleman.
Thank you, Lori, for that introduction. And thank you all for joining today. I will be discussing hormone replacement therapy, the indications for that, effects of hormone replacement therapy, as well as the misconceptions that have been related to this form of treatment. And the presentation is going to be geared more specifically towards treatment of adolescents. And so we will get going. So the objectives for today, we want to understand hormone replacement therapy and its uses. We want to learn the physical and emotional effects of hormone replacement therapy. We want to know when to initiate hormone replacement therapy. And we also want to clarify any misconceptions around hormone replacement therapy. So first of all, what is hormone replacement therapy? So, hormone replacement therapy involves administering uh, via oral medication, shots, transdermal patches, um, medications or hormones that align physical traits with the gender identity or to treat hormone deficiencies. Some different types of hormone replacement therapy. Um, for feminizing hormone therapy, we typically will use a combination of estrogen as well as anti-androgens. For masculinizing hormone therapy, we will typically use testosterone. And then prior to that, puberty blockers are often used in younger adolescents uh, with gonadotropin releasing hormone analogs, GnRH analogs. So, more specifically, the medications that are used in adolescent hormone replacement therapy. Testosterone, usually given intramuscular, transdermal, for masculinizing therapy. Estradiol, orally, transdermally, via injection for feminizing therapy. Again, those gonadotropin releasing hormone analogs, leuprolide, estrelin, are puberty blockers to delay the onset of puberty. Spironolactone, as well, an androgen blocker used with estrogen therapy in combination. So we should also begin first by talking about social versus medical transition. So both play roles in the transition of a young person or an older person. Social transition often will precede or will accompany medical care. So social transitioning is where persons may try out a new name, clothing, mannerisms, or changing physical characteristics such as hair, nails, to better match their gender identity. Medical transition, however, relates to the use of medications, puberty blockers, hormone replacement therapy, or later on gender-affirming surgeries. And so one thing to note about social transitioning is that this is something that is completely reversible if a person decides that um, they don't want those changes. Medical transitioning has parts of it that are reversible, but some parts that are not. So more specifically, hormone replacement therapy versus puberty blockers. So puberty blockers, again, delay puberty onset. Hormone replacement therapy induces secondary sex characteristics, and these are often used sequentially, with puberty blockers being used first. The effects of puberty blockers are completely reversible. Some effects of hormone replacement therapy are irreversible, though many are reversible or partially reversible. So, what are some of the indications for hormone replacement therapy? Many people coming to this presentation, I'm sure, are thinking about hormone replacement therapy, more so in terms of helping with gender dysphoria, helping to match gender identity. And so gender dysphoria is one of those indications for hormone replacement therapy. And more specifically, it's a condition marked by distress due to the incongruence between one's gender identity and the sex assigned at birth. But there are other indications for hormone replacement therapy. Endocrine disorders, conditions such as congenital hypogonadism, Turner syndrome, and Kalman syndrome, all may need hormone replacement therapies. Delayed or precocious puberty, hormone therapy may assist in normalizing puberty timing and development because kids that either have delayed onset or precocious, meaning happening earlier onset, can end up dealing with some pretty significant social functional issues as a result. So puberty blockers. So we know that they suppress puberty. This allows time for gender identity exploration. So it is typically started when a child reaches Tanner stage 2. Um, and so in terms of just physical characteristics for females, this is oftentimes when like breast bud development happens. For males, testicles tend to descend and lengthen at that point. But typically, females and biologic females, biologic males, um, will undergo puberty at different times. On average, females tend to hit Tanner stage 2 between the ages of 10 and 11, though the range can be anywhere from 8 to 13. When it happens before that, it's considered precocious. When it happens after, it's considered delayed. Males, the average age for Tanner stage 2 is 11 to 12, though again, that range can be from 9.5 to 15. And so, because there is such a wide average range of onset of puberty, working closely with a pediatrician and getting kind of Tanner stage assessment for kids that are gender nonconforming or considering puberty blockers is good to have on a regular basis. So, what are some of the effects of hormone replacement therapy? So, for testosterone, female to male transitioning, we're going to often see voice deepening. We're going to see increased body and facial hair. We're going to see fat redistribution, as well as menstrual suppression. For estrogen effects, male to female, we're going to see breast development. We're going to see skin softening, fat redistribution as well. Now, one of the things that people often ask is, when will these changes happen? How long will it take for my body to start changing? Well, many of the results actually do vary based on the individual and the dosing of the hormones that are used, because not every person is going to have the same dosage that they're given. But in terms of kind of range of time, you can start from masculinizing hormone replacement therapy with testosterone, start to see some skin oiliness and acne within 1 to 6 months, facial and body hair growth beginning between 6 to 12 months, but this can continue for 3 to 5 years. Voice deepening between 3 to 12 months, may stabilize after a year or two. Menstrual cessation, 2 to 6 months, muscle mass increase and fat redistribution over 6 to 12 months. For feminizing hormone replacement therapy, decreased libido or development of spontaneous erections between 1 to 3 months after initiating treatment, body fat redistribution 3 to 6 months, but continues for 2 to 5 years. Breast development begins around 3 to 6 months and will continue development for 2 to 3 years. Decreased muscle mass and strength, 3 to 6 months, softer skin, reduced body hair. These are gradual changes starting around 6 to 12 months. And again, as noted, the onset and the maximum effects are going to vary by individual and based on the dosage that are used. So prior to initiating any type of hormone replacement therapy, not including puberty blockers, it's really important to consider fertility. And it's important to discuss possible fertility preservation before starting hormone replacement therapy. So why is this important? Well, hormone replacement therapy can impact reproductive capacity. So early and informed discussions are really essential. So options like sperm or egg freezing should be discussed before initiating hormone replacement therapy. And the reason for that is some of the effects on fertility may be irreversible. particularly with prolonged use of estrogen or with testosterone. So a reproductive specialist should be a part of the care team when possible. And counseling should be developmentally appropriate and sensitive to future family building goals. And we will speak a bit more on this in a bit in terms of timing and when those conversations typically happen. So monitoring and adjustments. So anyone who's taking hormone replacement therapy should get baseline labs before initiating treatment, checking complete blood count, liver function, lipids, estradiol and testosterone levels at baseline, prolactin, renal function, and electrolytes. And then ongoing monitoring, usually every 3 to 6 months after initial baseline labs are taken, beginning serum hormone levels, which allows for more accurate adjustment of dosing, getting hemoglobin and hematocrit for testosterone, liver enzymes, annual lipid profile, and bone density if there are risk factors due to long-term puberty suppression. And this allows for making dose adjustments. So what are some risks and side effects of hormone replacement therapy? So it may include cardiovascular, liver, or bone impacts, and it does require supervision. So for masculinizing hormone replacement therapy, we could see elevated red blood cell count, which is polycythemia, liver enzyme elevation, acne and oily skin, potential increases in cholesterol and LDL, mood changes or aggression in some patients, or sleep disturbances. For feminizing hormone replacement therapy, there can be an increased risk of blood clots, especially with oral estrogens. There can be elevated triglycerides, liver enzyme changes, decreased libido and sexual function, weight gain and fatigue, and increased risk of prolactinoma. So, what are some of the emotional outcomes? Evidence supports improved mental health in adolescents receiving hormone replacement therapy. In fact, there do not seem to be any studies showing results indicating negative emotional outcomes of hormone replacement therapy in adolescents. So looking at this chart, what we are seeing is mental health outcomes before and after hormone replacement therapy. So before the graph in bluish purple, you're seeing elevated scores of depression, anxiety, self-esteem, or lower self-esteem, lower life satisfaction. And after therapy initiation, we're seeing markedly decreased rates of depression and anxiety, as well as elevated self-esteem and life satisfaction. Long-term mental health benefits, too, show the same. Decreased scores in depression and anxiety, improvement in life satisfaction. And again, these are studies reproducible and that have been shown to be consistent. Family and social support is really crucial to positive psychological outcomes. Aside from with friends, adolescents typically spend the majority of time either at school or with family. So education and support is the most critical for these persons. Unfortunately, not all family or friends are supportive of gender-affirming care, and this negatively affects mental health outcomes. So what are some of these potential stressors that can negatively affect mental health outcomes? Social stigma, limited access to care, or body image issues. So in terms of social stigma, peer bullying and exclusion in schools has been shown to be fairly prevalent. Misgendering and lack of acceptance in social settings. Discrimination from healthcare providers. In terms of access to care, there can be a shortage of knowledgeable providers, especially when it comes to hormone replacement therapy or gender affirming care, especially in more rural areas. Insurance denials can be common for gender affirming care, and there could be high out-of-pocket costs, limiting access to a large portion of patients. There can also be legal barriers to care in some regions. And there's a high stress-related component in terms of body image, when it, which is usually co-occurring with body dysmorphia or with gender dysphoria. Up to 48% of youth with gender dysphoria do report symptoms of body dysmorphia, and can worsen mental health outcomes if untreated. Utilizing gender affirming care with hormone replacement therapy has been shown to improve rates of body dysmorphia. In terms of guideline recommendations, would refer you to the WPATH and Endocrine Society guidelines, which typically recommend beginning hormone replacement therapy around the age of 16. And so, going back to what we talked about initially in terms of fertility counseling, those discussions oftentimes will begin, around the age 14, 15, 16, prior to the initiation of hormone replacement therapy, and around the time, when kids are more knowledgeable about sex anyway. So those conversations typically are not happening with little kids, with middle school or younger. Those conversations typically are reserved for older teenagers. And so the guidelines for both of these standards of care for hormone replacement therapy are available online. And again, they do, in general, recommend individualized treatment plans, frequent follow-ups, and stressing the informed consent process. Which leads to informed consent and capacity. So this involves understanding maturity levels and sometimes parental consent. So informed consent is a process in which a patient understands and agrees to treatment based on full disclosure of risks, benefits, and alternatives. Capacity is the ability of an adolescent to understand treatment implications and make reasoned healthcare decisions based on their understanding. This is determined through both cognitive and emotional maturity, understanding of the medical information presented, consistency in expressed gender identity over time, as well as support for mental health professionals. Parental consent is often legally required for minors under 18, depending on local and state laws. It is required in most U.S. jurisdictions for initiating cross-sex hormone therapy. And then, exceptions may include instances of emancipated minors, and these are usually going to be older teenagers, usually 15 or above, who have shown ability to take care of themselves, usually working, and showing that over time. And so there are some exceptions where parental consent is not required. So in terms of specifically Illinois laws on hormone replacement therapy for adolescents, parental consent is required for minors under 18. So there is the mature minor doctrine. So Illinois recognizes this, again, allowing some minors to consent to medical treatment if they demonstrate sufficient maturity and understanding. However, this is typically applied in specific medical situations and may not extend to hormone replacement therapy without parental involvement. And so oftentimes in cases where there is question about whether a minor can give consent by themselves, attorneys and legal orders are generally needed at that point in time. So exceptions, there are limited exceptions where minors can consent to certain medical treatments without parental approval. such as for STI treatment and substance abuse services. But these exceptions generally do not include hormone replacement therapy. So trying to kind of clarify myths on hormone replacement therapy with facts. And so we'll look at a couple of different questions at this point in time. So question one, which of the following are reversible effects sorry, this should say which of the following is not a reversible effect of hormone replacement therapy. So again, the question, which of the following is not a reversible effect of hormone replacement therapy? Breast growth, skin texture changes, testicular atrophy and decreased sperm production, fat redistribution, cessation of menstruation. And again, that's which of the following is not a reversible effect of hormone replacement therapy. And so the answer is C. Testicular atrophy and decreased sperm production is typically not reversible after prolonged estrogen therapy. Question two, which of the following are true of hormone replacement therapy? Most people receiving hormone replacement therapy regret their decision. HRT, hormone replacement therapy, often causes serious health problems. Multiple studies indicate that a hormone replacement therapy causes long-term harm. Most patients don't continue to seek gender-affirming care after starting hormone replacement therapy. And longitudinal studies report improvements in mental health, social functioning, and well-being for those using hormone replacement therapy. So the answer here is E. Longitudinal studies do report improvements in mental health, social functioning, and well-being in general when HRT is used. And question three, which of the following are needed before initiating hormone replacement therapy? Comprehensive psychological evaluation, medical history and physical examination, pubertal status assessment, informed consent process, multidisciplinary team involvement, fertility counseling, baseline laboratory testing, or all of the above. And so the answer is all of the above. Hormone replacement therapy does require significant assessment prior to initiation. So, one of the myths surrounding hormone replacement therapy is that it is given too easily. This just is not true. Hormone replacement therapy requires thorough assessment and evaluation. So as we previously discussed, there's comprehensive psychological evaluation. We're assessing gender identity, as well as the stability of gender identity over time, mental health, readiness for treatment, as well as support systems that are in place. Having a complete medical history and thorough physical examination can help identify any underlying health concerns or contraindications to therapy. The pubertal status assessment is to determine Tanner stage and appropriateness for puberty blockers or hormone replacement therapy. Informed consent ensures that the adolescent and guardians understand benefits, risks, and long-term effects. Multidisciplinary team involvement is usually with collaboration among endocrinologists, mental health professionals, as well as primary care. Fertility counseling, again, discussing options for fertility preservation prior to treatment initiation due to potentially causing irreversible effects on fertility. And then baseline laboratory tests, including hormone levels, liver function, lipids, and other relevant markers. Hormone replacement therapy is irreversible. Well, this is partially true. Some effects of hormone replacement therapy are completely reversible, while other effects are partially reversible or only reversible with surgery. Some effects are not reversible. So, what is reversible and what is not? Fat redistribution, skin texture changes, cessation of menstruation, breast growth in the very early stages, and emotional or mood changes are all fully reversible. Muscle mass changes may be partially reversible. Breast development, the tissue may become permanent, though corrective physical surgery, breast reduction can help with that as well, if desired. Some, though, irreversible effects: facial and body hair growth, clitoral enlargement, testicular atrophy, and decreased sperm production, and deepening voice are all things that are typically not reversible. Hormone replacement therapy harms health. Well, this is not true. When monitored, risks are low and benefits are significant. As in any area of medicine, we are always trying to weigh the risk of treatment versus the benefit. And though, as I mentioned, there are side effects to treatment, when properly monitored, multiple peer-reviewed studies show that hormone replacement therapy is safe when administered under clinical supervision. The longitudinal studies report improvements in mental health, social functioning, and well-being. Common side effects, such as changes in lipids or blood pressure, are manageable with regular monitoring. Major medical organizations, such as the Endocrine Society, WPATH, and AAP, all endorse hormone replacement therapy as part of gender-affirming care. There is no evidence supporting claims that hormone replacement therapy causes long-term harm when provided according to guidelines. And the psychological benefits significantly outweigh manageable physical risks. People regret receiving hormone replacement therapy. This is not true. An extremely small percentage of patients receiving hormone replacement therapy regret their decision. High satisfaction rates reported in adolescents undergoing gender-affirming hormone therapy are common. A 2022 study in JAMA found that 98% of transgender youth continued to desire gender-affirming care treatment after starting hormone replacement therapy. Reported benefits include increased self-esteem, reduced depression and anxiety, as well as improved quality of life. And in terms of regret, extremely rare among adolescent patients receiving hormone replacement therapy. Another study from 2022 found regret rates below 1%. Regret, when it occurs, is more often associated with lack of social support or external pressures than dissatisfaction with the hormone replacement therapy itself. Parents are left out. This is a very, very common myth regarding hormone replacement therapy because parents are usually involved from the beginning and play a supportive role. So parents or legal guardians are typically required to be provided informed consent for minors to begin hormone therapy. Parental support is also critical for the adolescent's psychological well-being and treatment adherence. So education and support for parents is very, very crucial. And the education should be coming from this multidisciplinary team approach, consisting of social workers, psychiatrists, therapists, pediatricians, endocrinologists, and so forth. They can help educate families on hormone replacement therapy benefits and risks, emotional and developmental considerations, fertility preservation options, as well as long-term health and wellness strategies. And again, in Illinois state law, parental or guardian consent is typically required for hormone replacement therapy in minors. It's much easier to have a parent consent to treatment if you have spent the time to try and help educate, answer questions, be empathetic, and also understand that not everybody comes from a place where they are fully understanding of gender diversity. Many people grow up in areas where this is not something that's known or something that is not talked about freely. And so being able to take time to provide that compassionate education for parents and hopefully from a non-judgmental perspective can really make all the difference, especially for your patient, for your student, or for the kid that you're working with. And so the state encourages shared decision making, though, between youth and families through informed discussions with clinicians. Providers often assess both adolescent capacity as well as parental understanding before proceeding. And so, again, collaborative approaches really do strengthen outcomes and reduce the risk of regret or misunderstanding, both amongst patients and their families. So, it's just a trend. So, data shows that gender identity is deeply rooted and persistent. Historical records from modern through ancient times have documented the presence of gender nonconforming persons, though they went by many different names depending on the culture and the era. Terms like transgender are newer terms developed in the 1950s and 1960s. So some examples of different historical or cultural recognitions of gender diversity. Two-spirit within the indigenous North American cultures, a sacred recognized identity in many Native American tribes, embodying both masculine and feminine spirits, often held ceremonial or spiritual roles in their communities. And I do apologize if I get any of this information incorrect. I'm always learning about these things myself. So if I have misunderstood any of these specific gender diverse presentations, I do apologize. In Southeast Asia, or sorry, South Asia, recognizing third gender in India, Pakistan, and Bangladesh for centuries. Traditionally, these roles have involved in blessings and rituals and cultural ceremonies. In Samoa, individuals assigned male at birth who embody both masculine and feminine traits, accepted invisible identity in Samoan society. In Albania, the sworn virgins, women who take a vow of celibacy and live as men to assume male roles in patriarchal communities. So again, gender diversity has been known. It's not something that's new. It's not something that's a trend, and something that, with better understanding, we can help support the well-being of so many people out there who do not identify in the binary of male or female. So some ethical duty, discussing ethical duty and the dilemmas in adolescent gender affirming care. So there is an ethical duty for physicians to provide care to patients. Physicians have a professional and ethical obligation to provide medically necessary care, and gender affirming treatments like hormone replacement therapy would be considered medically necessary care to patients with gender dysphoria or other other illnesses or genetic conditions requiring hormone replacement. Gender affirming care is endorsed by major medical associations as essential for health and well-being. And the principle of beneficence here, doing good and non-malfeasance, avoiding harm, support the use of hormone replacement therapy to alleviate gender dysphoria. Ethical dilemmas typically arise when there is parental disagreement with treatment. Challenges arise when adolescents seek hormone replacement therapy, but one or both parents are in opposition. Providers must try and balance the adolescent's autonomy and best interest, the legal requirements for consent, and respect for family dynamics and values. In some states, again, mature minors may be able to consent independently. In others, providers may seek legal intervention to resolve disputes, which is typically the intervention that must occur if there is an impasse with parents not being in agreement with hormone replacement therapy. But ongoing communication, mediation, and family counseling are still crucial in reaching a collaborative solution. So supporting adolescents with gender dysphoria in the school setting. So some ways that teachers and staff can support adolescents: use a student's chosen name and pronouns consistently, provide a safe and inclusive classroom environment free from bullying, respect students' privacy regarding medical information, such as hormone replacement therapy, allow access to facilities that align with students' gender identity, connect students with school counselors or LGBTQ support groups, be aware of warning signs of distress and refer to mental health professionals as needed, as well as educating peers through inclusive curriculum and activities that affirm diverse identities. We also, again, not just need to support the kids, but support the parents of gender diverse adolescents. We can offer through school, they can offer parents education nights or workshops on gender identity and adolescent development. They can provide respectful, non-judgmental communication and answers with accurate information. And this, I think, is one of the most important keys here. It's very easy to get frustrated when people are not in agreement, but continuing to be judgmental or disrespectful is more often than not just going to entrench a person into their beliefs. And so trying to come from a non-confrontational approach and very much just providing accurate, specific information can be a beneficial strategy. It's important to refer parents to qualified mental health professionals or support groups familiar with gender diverse youth. And so oftentimes parents will get a lot from hearing how other parents have handled, having a gender diverse child or friend or family member. And so having that support through building a community is also very, very beneficial and critical. So you can also share resources, such as the guidelines we talked about, local advocacy organizations, trans rights groups, and things of that nature, and get parents connected with other supports. It's important to acknowledge parental concerns, but still while affirming the student's identity and medical needs. And it's important to encourage open family communication and provide referrals to family counseling if appropriate. So here are some of the kind of different, more national, a few Illinois-based organizations that help support gender diverse adolescents and their families. There are many other organizations out there. It is typically as straightforward as getting on Google and searching for support group or organization that will help with gender diversity or trans rights. And there are many people out there and many organizations out there looking to help.
Dr. Coleman, Dan
Yes.
has a question.
Oh, sure.
He asks, how does HRT impact medication management, especially when dealing with suicidal ideation?
Sure. So with hormone replacement therapy, again, that's why it's important to have a combined multidisciplinary team. So I have worked with multiple patients who are on hormone replacement therapy. That specifically is not going to cause suicidal ideation. In fact, the majority of patients who deal with depression and suicidal ideations receiving hormone replacement therapy for gender dysphoria do show a reduction in suicidal ideations and suicide attempts. So the medicines to the hormones typically are not going to cross-react with psychotropic medications. Again, these are hormones that our bodies are producing naturally if we were assigned the gender at birth that we identified with. And so in managing it, it's a lot to do with the psychiatric evaluation and consistency. But in general, hormone replacement therapy does not show increased rates of suicidal ideation. I hope that answered your question.
And then we have another question.
Mhm.
What is the impact of someone having to go off of progesterone due to depressive symptoms?
Sure. So, if we're talking here about, um, you know, things like um, birth control, we do know that um, there are increased rates of things like depression or anxiety amongst treatment with things like that. And so if we see that, we typically will use different options. And again, in hormone replacement therapy, if we see that, they may try a different approach in terms of, transdermal versus oral applications. Um, but I guess if the question is like, what do you do if someone is on progesterone and develops increased depression? It would be working with, endocrinology, OB-GYN to look at finding a different option for that. But we do know that some use of like oral contraceptives specifically can increase rates of depression or anxiety.
And then we have another question from Dan. How do you prepare teens and families for what to expect from mood changes due to the increased hormones in their bodies?
So I typically, it's the same conversation I would have with any kid going through puberty. Just talk about how they may notice these things. They may notice, increased irritability. They may notice sleep disturbances. They may notice some anxiety. They may notice mood swings, and talk to them about how like, this is a natural part of adolescence in terms of pubertal development. Not everybody is going to have significant mood changes or swings, but some may. And so just letting them know ahead of time that these are things that we may expect to see. And I often encourage patients and parents to keep mood diaries. So just even as simple as like a calendar and noting like this is my mood, and maybe check in the morning, check in the evening, and have parents track it as well. So are parents seeing kind of the same things that the kid is feeling, or having the same report? And so I think that tracking that as well as preparing them ahead of time can be really beneficial. And then if you start seeing dysregulation, or you start seeing patterns develop, if you've been tracking it, it can be a lot easier than, can we identify specific triggers for this, or is it just coming out of the blue? And at that point, too, there can be dose adjustments in the specific levels of hormone replacement therapy. They can be lowered if we're concerned that that may be having an impact.
Thank you. And then Chrysantha asks, how do you help the parents of a gender dysphoric child address their potential grief over losing their child's known gender or even fertility?
Yeah. So, well, first of all, there's those fertility preservation options. So it's definitely something that we discuss. So, and again, this is more specific. I have a very different perspective on this than many people. I am the parent of a transgender child, so I've had to go through. I suppose you would call it grief, though I don't believe I experienced that in the same regard as other people have. Though I have worked with parents who have expressed that loss of grief, or expressed that sense of grief and loss. What I typically try and talk to them about is your child is still the same child. Your child is still your child. Their personality is probably not going to really change. What they care about, what their values are, probably not going to change. The only thing that's really changing is how they, are expressing themselves. And so what I typically will also caution parents about is recognizing, yes, that there is grief. I also recommend that if they are experiencing that feeling of grief or loss, that they get an individual therapist themselves so that they can have someone to talk to regularly and get support from in that regard. I try and put them in support with, other support groups or communities where there's lots of support groups out there for adolescents and families of gender nonconforming teens. And so being able to get the support and hear from other parents who have experienced that loss and how they have moved forward from it, I think can be very beneficial. Um, but also really trying to acknowledge that what we see is that if parents are not supportive, and again, there's a difference between like misgendering unintentionally, because I also try and prepare the kids that, especially if they're older and kind of transitioning, like their parents have formed a habit of a way of thinking, a way of addressing, and it's hard to break habits. And so even though they may be trying, they may still misgender or use improper name or pronouns at times. But I think kids in general can tell if a parent is trying. And so that's the big difference. And so I really encourage them to try, to understand that the noted medical benefits, the noted emotional benefits from hormone replacement therapy are like huge. I mean, they're massive in terms of the response that if they are really there and wanting to support their child the best they can, that this is going to do them benefit. And that, as parents, we always have to try and prepare ourselves for loss, but that this is, it's made. I try and look at it not as a loss, but as telling them this is your child gets to be like who they are. Your child, gets to understand that their parent is okay with, like, that truly is that kind of unconditional love part. And so I try and have that conversation with parents. I also try and have that conversation usually initially with parents individually and not with the adolescent present. Just because it's typically a parent is going to be much more open about their feelings without the patient there. So, and I also think that too, that gives the parent a little bit of leeway in terms of not feeling, pressured to say the right thing in front of their kid. So, sorry, I know that's a very long-winded explanation, but parent education and talking about that loss is a very real thing. So,
So helpful. We have another question, and we have time for maybe one more question after this to our audience. Um, so if you want to put another question in the chat or the Q&A, this question is, do you have any guidance on what to say to parents who are adamant about not using the child's preferred pronouns or names and the impact that has?
yeah, absolutely. And so when things like this come about, again, trying to come from a non-judgmental point, like place, and really just saying to the family, look, I understand that this is how you feel. What I would like to do is communicate to you what is seen in research about the negative emotional effects when this is going on. And so there are, again, multiple studies out there showing that when patients are misgendered, when they do not feel seen, we are looking at increased rates of depression. If we're looking at increased rates of anxiety, increased rates of suicidal ideations and attempts, both non-lethal and lethal. And so I tell them those things, and I say, look, if you are firm in your stance, then I want you to expect that some or many of these things could happen, and your child could suffer as a result. So if that is what you are wanting, if that's your goal, then that's there. But if your goal is not to make these things happen, if your goal is to, for your kid to feel okay, then I would really strongly urge you to consider using the name that they want, or the pronouns that they feel are appropriate to their gender, and see, because I just tell them point blank, I do not expect that it will help, and I expect that your child will be upset and also potentially resent you and not want to have a relationship with you in the future. So I think being open and straightforward about it and providing facts is the best approach. And also trying to align with that most parents are doing what they are doing because they believe it is in the best interest of their child. So confronting them with the facts of this is what the research shows will likely happen. And if you're really wanting the best interest of your child, then I advise not doing that or doing something different. So, and hope that they listen.
This is so helpful, Dr. Coleman, and we appreciate you sharing your personal experience um, with your child, and that's very impactful. Any other questions that you have before we close for the day? We want to make sure we address anything that and not leave it out. And I'll give you a minute to type in if you need to, or unmute to ask. Dr. Coleman, would you mind sharing our flyer at the beginning? Because I think this kind of leads into, not only we would want you to, refer a student that you feel might need extra support going through these transitions. But not only we would want you to go ahead and give us a call and help schedule an assessment, and Dr. Coleman does many of these assessments, but also that we do have a summer transitions program. It's not, it sounds like it would just be for transition in transgender, but it's for all transitions that all teens face, whether it be in school, at home, personally. But this summer program is really geared to help them to develop techniques and new ways of being able to think in order to be able to cope better and to support their families through whatever transitions they're going through, to help give them that kind of summer structure. And so you'll be getting that flyer with the PDF presentation today. So you'll be able to share that with parents that are interested in a summer program and so on and so forth. So, any more questions before we leave each other for today? Yeah, so that starts June 9th, and it's a whole day program, and it's going to be really geared toward helping empower our students to get through the challenges that they face in the upcoming year and whatever they're dealing with in their personal lives and in their families. So we hope that you'll be able to share that information with your parents and your teams. Most of you have met with us and know us, and Donna and I are here as a resource, and we just so appreciate Dr. Coleman, you sharing this important information, and we hope that it's been helpful to you, and we look forward to your feedback and continuing to support you and your students and your families. So we hope it was helpful and begins more good conversations as we all learn together. So thank you all. We'll see you next time.
All right. Thank you,
Have a good
everyone.
Take
afternoon.
care.
Bye.
Bye-bye.